Rahim. I'm Dr. Mohammed Shoaib, and I'm working as SR in PIMS Hospital. And thanks for Pakistan Cardiac Society for giving me the opportunity to present on this forum. And the presentation for today is rheumatic heart disease. It is still prevalent. And we will discuss the management of rheumatic mitral stenosis according to the latest guidelines.
Shall we start?
Sir, I've started. Can I continue?
Sir.
शुरू करें?
Sir.
आवाज नहीं ठीक आ रही.
Sir, we can all hear. आपके connection का issue है. The lecture has already started.
So, rheumatic heart disease, it is the most common acquired heart disease in people under age 25. The disease results from damage of heart valves caused by one or several episodes of rheumatic fever and autoimmune inflammatory reaction to group A streptococcal infection. And it is a preventable disease. So this is the...
Dr. Shoaib, can you hear me?
I can hear you, sir. I can hear you.
Hello?
Sir, I can hear you.
Hello?
Sir, I can hear you.
क्या मसला क्या है?
या शोएब भाई आप ना बस लेक्चर चलाते जाएं.
ठीक है
वो सर का कनेक्शन का इशू है, वो नहीं होगा, वो सर ऐसे होता रहेगा. बस आप जस्ट चलते जाएं.
This is the history of advances in rheumatic heart disease. So you can see that from 1930s to 1960s, this is the era of discovery of treatment of rheumatic fever. And it was discovered by Jones, and it was treated with antibiotics. And once the patient developed pharyngitis, Dr. Jones was successful in treating and prevention of acute rheumatic fever after acute pharyngitis. So this was a great achievement. Then for the next 30 to 40 decades, there was a standardization of rheumatic fever guidelines, like diagnosis of rheumatic fever. Then after that, for about 3 to 4 decades, there is stagnation of research in this field, because this disease, it disappeared from the developed countries because of use of antibiotics. But once the migration started to developed countries from the non-developed countries or advancing countries, the disease also become somewhat prevalent in those countries. So again, research started, and with this, they come to programs like screening programs. They develop vaccinations. So some vaccines, like 5 vaccines, are currently approved by FDA, which can be given in patients with rheumatic heart disease. So this is the prevalence of rheumatic heart disease. About 40 million cases of rheumatic heart disease are present worldwide. Highest prevalence in Oceania, South Asia, and Sub-Saharan Africa. Non-endemic regions are those in which there are prevalence of about 3 to 4 cases per lakh. And in endemic areas, the prevalence is much higher, and it is about more than 1,000 cases per lakh. 3 to 4% of the population is high risk. In high risk area are susceptible to develop rheumatic heart disease. This is the global prevalence. You can see that in Pakistan and India, we carry the largest dot, which means that there is a high prevalence of rheumatic heart disease in our area. And so this is the burden of disease. About 2.6 lakh to 3 lakh deaths occur per year. 132 disability adjusted years per lakh for rheumatic heart disease, and the mean age of involvement is 28, and it is more common in females. So you can see that it is a disease of prime of age, and female which are in reproductive age, they are also affected, which can greatly increase the disease burden. Long-term sequelae are moderate to severe multivalvular disease, which is 64%. 33% of the patients develop congestive heart failure. 29% of the patients develop severe pulmonary hypertension. 22% of the patients develop atrial fibrillation. Stroke is common in 7% of the patients, and it causes premature death. So this is the situation of rheumatic heart disease in Pakistan, which is horrific. prevalence of rheumatic heart disease in Pakistan is about 2,200 per lakh, and 2.1 million patients are estimated to be affected in 2019. And the number greatly increased, and about 11,000 deaths occurred in just 1 year, which was 1990, and 27,000 deaths were in 2019. So you can see that the death toll of rheumatic heart disease is increasing, even with the advancements in the health facilities. So this is the natural history of disease. Patient living in poor, overly crowded areas with poor hygiene, they are prone to develop frequent infections like pharyngeal infections or even skin infections. And if they are susceptible, have genetic susceptibility to rheumatic heart disease, they can develop rheumatic fever. And if the rheumatic fever is not treated or with the recurrent episodes of rheumatic fever, advanced rheumatic heart disease develops, and which further leads to hemodynamic compromises. So acute rheumatic fever should be discussed when we're discussing with we are discussing rheumatic heart disease, and it is a sequelae of streptococcal infections of throat or skin, almost equal incidence in male and female, typically follow 2 to 3 weeks after group A streptococcal pharyngitis. The main mechanism is molecular mimicry and cross-reactivity, but other mechanisms are also present, which are hypothesis of collagen-associated neoantigen epitope spreading. Then T-cell receptor degeneracy is another mechanism. So this is the mechanism of acute rheumatic fever and prevalence of rheumatic heart disease. You can see that the incidence of acute rheumatic fever peaks at age of 5, then decrease after age of 24. So that's why we give secondary prophylaxis about up till about 25 years of age. And you can see that the prevalence of rheumatic heart disease, it increases till 35 years of age, then it declines. The decline is because of patients who die from the disease. So pathogenesis of rheumatic fever, streptococcal pharyngitis causes the exposure of body to different proteins. The main protein is the protein M. And once it is presented to antigen presenting cells, T cell activation occurs, and T cell and B cell activation occurs, and B cell produces cross antibodies, which react with the joints, would react with the endothelium, would react with the subcutaneous tissue, and it also can destroy the brain tissue. So these are the examples of group A streptococcal infections. More common is pharyngitis, which cause acute rheumatic fever, but skin infections like impetigo can also cause rheumatic heart disease. So this is the assessment of patients who present with sore throat. If the patient is present in a high-risk area, and he develops any sign of gas infection like throat culture, like ASO titer, like DNase antibody, the second prophylaxis should be started straight away. But if the patient is in a low-risk area, then we have to send throat swab, and if the culture is positive, then we have to start antibiotics. So this is the modified Jones criteria. It was modified for the population of Oceania, which includes some areas of Australia and New Zealand, because in those areas the rheumatic heart disease is still very prevalent. And in the modified form, for definitive initial episode of acute rheumatic fever, 2 major manifestations and evidence of preceding streptococcal infection should be there. Then 1 major and 2 minor manifestations should be there, along with evidence of preceding gas infection. Then for a definitive recurrent episodes of acute rheumatic fever in patients with a documented history of acute rheumatic fever or rheumatic heart disease, the criteria is same, but the third thing is that the 3 minor manifestations along with the gas infections, it confirms the diagnosis of acute rheumatic fever. And by the way, the low risk populations are those in which the rheumatic fever incidence is less than 2 per million school going children, while for all age rheumatic heart disease patients, 1 per 1,000 population per year is those who are in low risk area. Anything above this, those are living in a high risk area, and they should be treated as a modified cases. So these are the major manifestations: carditis, polyarthritis, Sintihan's chorea, erythema marginatum, and subcutaneous nodules. These are the major manifestations in low risk area. While the aseptic monoarthritis and polyarthritis, they are added in major manifestations in high risk area. And minor manifestations are fever, monoarthralgia, ESR, and raised CRP, and prolonged PR interval on ECG. And in high risk area, the monoarthralgia is also included in the minor criteria, while the polyarthralgia is included in the major criteria. So this is the case scenario. A 10-year-old female resident of Rawalpindi, student of 5th grade, presented to us with the complaints of fever, arthralgia of both knees and ankle. There is no previous history of rheumatic fever. On examination, her temperature was 39 degrees centigrade. Cardiac and respiratory examination is normal. No swelling or tenderness noted in joints. Normal range of movements. Echo is normal. ASO titer was raised, and ESR is 66. Is this presentation regarded as a definitive episode of acute rheumatic fever? The answer is yes, because the patient is living in a high risk area, and in these patients, the polyarthralgia is also included in major manifestation. So she has one major manifestation and 2 minor manifestations, along with the evidence of gas infection. So this fulfills the criteria of acute rheumatic fever, and she should get the secondary prophylaxis. These are the explanation for the major manifestations. We will discuss just briefly. The arthritis is usually a migratory polyarthritis, and it responds to NSAID very quickly. Then Sydenham's chorea is more common in female, and it is usually accompanied with carditis. And the carditis usually presents with the sign and symptoms of mitral regurgitation and aortic regurgitation, and it can also occur in patients with subclinical disease. Then subcutaneous nodules, these are also pathognomonic, and erythema marginatum, this is a erythematous rash which has central clearing, and this is also pathognomonic for rheumatic heart disease. So you can see it in the diagrams. You can see the arthritis of the joints, and you can see the rash. And these are the minor criteria: the arthralgia, the fever. Fever is different in high risk and low risk. Like in high risk population, even 38 degree centigrade is taken as minor criteria manifestation, while in low risk area, 38.5 or higher is taken as minor manifestation. Below this, it is not taken as minor manifestation. The other are the elevated acute phase reactants and ECG changes. If the patient is already having carditis, then the prolonged PR is not included in minor manifestation. So this is the degrees progression. Acute rheumatic fever patients, they progress to rheumatic heart disease in 10 years, about 52% of the cases. And once they develop the rheumatic heart disease, the progression from rheumatic heart disease to severe rheumatic heart disease occurs in 10 years. About 35% of the patient, they develop severe rheumatic heart disease. And you can see that at year 0, 10% of the patients are also having severe rheumatic heart disease, because it is a somewhat subclinical disease as well. So some patients, about 10% of the patient, they come to know about the severity of disease at 0 years. So this is the second prophylaxis for acute rheumatic fever, and this is a class 1 indication. We can give 1.2 million units of penicillin G benzathine intramuscular every 4 weeks in high risk areas, and every 3 weeks in low risk areas. And penicillin V can be given orally 20 milligrams twice daily. And sulfadiazine can be given if the patient is allergic to penicillin 1 gram orally once daily. Macrolides and azelides can also be used if the patient is allergic to penicillin. So this is the duration of prophylaxis for patients who are having carditis and residual heart disease. The prophylaxis should be continued for 10 years or until 40 years. Which one is the longest? In high-risk areas, the lifelong prophylaxis is needed. And for patients who are having carditis with no residual disease, the second prophylaxis should be continued for up to 21 years or for 10 years, which one is longer. And for rheumatic heart disease without carditis, 5 years or until a patient is 21 years of age, whichever is longer. So this is the effectiveness of penicillin prophylaxis. You can see that once a patient develops gas infection, once we treat the gas infection, in 32% of the cases, we prevent the rheumatic fever. And once the patient develops rheumatic fever, then we can prevent secondary episodes by giving secondary prophylaxis in 84% of the patients. So the penicillin prophylaxis is highly effective in patients with acute rheumatic fever. So these are the opportunities to combat acute rheumatic fever. Like if we can decrease the exposure by improving the living conditions of the patient. And once the patient develops throat infection, if we suspect the gas infection, we should treat there and then. If the acute rheumatic fever starts, then we have to treat acute rheumatic fever, and we should counsel the patient to receive secondary prophylaxis so that he doesn't develop any secondary complications. Once the patient develops complications, we have to develop good access to anticoagulation. We have to develop good access to surgical interventions so that we prevent long-term complications. These are the frequency of valve involvements. Mitral valve is involved in about 70% of the cases, and in 30% of the cases, only mitral valve is involved. And in 15% of the cases, in 3% of the cases, aortic valve is involved. So this is the acute rheumatic. This is the rheumatic mitral stenosis. It occurs 2 to 20 years after acute rheumatic fever. About 50% of the patients are not aware of history of acute rheumatic fever. 2 to 3 times more frequent in women, and thickening and calcification of valve leaflets and subvalvular apparatus leading to stenosis. You can see that in a diagram as well. On the right is the mitral valve. On the left is the normal tricuspid valve. And the complications of rheumatic mitral stenosis include left ventricular enlargement, systolic embolization, which occurs in 10 to 20% of the cases, atrial fibrillation, congestive heart failure, pulmonary infarction, susceptibility to pulmonary infections, infective endocarditis, left ventricular systolic dysfunction can also occur. These are the stages of mitral stenosis according to guidelines. Those patients who are at risk are allotted stage A. And those who develop carditis, they are allotted stage B, and those are the ones.
MashaAllah, dera خوشحالی مجلسه تاسو دې څه په کې یو واقع له فرق شته کنه نو هغه د فرادیس.
These are the patients who have mitral valve area less than 1.5 centimeter, and the diastolic pressure half time less than 150 milliseconds. Once it gets above this, they develop severe mitral stenosis. They can be symptomatic, they can be asymptomatic, and these are some findings of echo findings of these are some echo findings of mitral stenosis in rheumatic heart disease. You can see the thickening of mitral valve. You can see the hockey stick appearance of anterior mitral leaflet, and you can see the mean gradient, which is increased in case of severe mitral stenosis. So the initial diagnosis is made on transthoracic echo. And if the patient is having features of mitral stenosis and he needs PTMC, then we can do a transesophageal echo to rule out LA thrombus and to rule out the severity of MR and the suitability of valve for PTMC. This is the Wilkins score, which we can grade it on the scale of 16, and it has 4 criteria: mobility of valve, thickening of valve, calcification of valve, and subvalvular thickening. And the score greater than 8, the score less than 8 makes the patient favorable for percutaneous transmitral commissurotomy, and a score between 8 and 12, it is a gray area. The score greater than 12, it has poor results for PTMC. So if the patient is asymptomatic, then exercise testing could be done to demonstrate any decrease in exercise capacity, or to see the response of mean mitral gradient and pulmonary artery pressure with exercise. This is the frequency of monitoring which we have to be done for progressive disease. We have to do echo every 3 to 5 years if the patient is not having symptoms or new symptoms. If the patient is having severe asymptomatic disease, then the monitoring should be done every 1 to 2 years, or in case of very severe mitral valve disease, every year. Medical treatment, it includes warfarin, which is given in cases of rheumatic fever and atrial fibrillation, or any prior embolic event, or any LA thrombus. And for the patients who have atrial fibrillation, rate control strategy can be beneficial. And for patients who are having tachycardia, beta blockers are indicated. This is a class 2 indication. These are the guidelines for the intervention. The class 1 indication is symptomatic patients having NYHA class 2, 3, 4 symptoms with severe rheumatic mitral stenosis with mitral valve area less than 1.5 centimeter square, are favorable valve morphology with less than moderate MR in absence of LA thrombus. PTMC is recommended if it can be performed at a comprehensive valve center. The other class 1 indication is a severe symptomatic patient having NYHA class 3, 4 symptoms with severe mitral stenosis, and the candidate he's not a candidate for PTMC, or have failed previous PTMC attempts, or require other cardiac surgery. In these patients, the mitral valve replacement is indicated. Then the two indication is in asymptomatic patients with severe rheumatic mitral stenosis and favorable valve morphology less than 2 plus MR in absence of LA thrombus with elevated pulmonary pressure. PTMC is reasonable if it cannot be performed at a comprehensive valve center. So these are the other 2B indications. We proceed to PTMC. This is you can see. This is we take the venous approach, and we reach the RA. Then we pass the interatrial septum. We reach the mitral valve. First, we inflate the distal balloon, and then we inflate the proximal balloon. Then we reach the required size. So this is the brief process of PTMC, and these are the criteria for selection of patients for PTMC. Age is main. It is difficult in extreme of ages. So in extreme of ages, mitral valve replacement is superior. Then pulmonary hypertension with right-sided heart failure is also a relative contraindication. Previous PTMC or surgical valvotomy, it makes complicated. Then atrial fibrillation, LA thrombus, atrial appendage thrombus, associated aortic valve disease, associated tricuspid valve disease, associated MR, mitral valve morphology. All these should be considered before booking a patient for a PTMC. And then comes the mitral valve replacement. So there are 2 types of valves. Both have their advantages and disadvantages. The bioprosthetic valves are having low risk of valve thrombosis and reduced need for anticoagulation. While the disadvantage is structural valve deterioration. Then the mechanical valves have longer durability, superior hemodynamic profile, and the disadvantages are the valve thrombosis are frequent and long-term anticoagulation is needed. We will skip this. And this is the summary of indications for patients who are having severe mitral stenosis. If they are symptomatic and they fulfill the criteria for PTMC, it is the class 1 indication. If they are not symptomatic, then if they are having NYHA 3 or 4 symptoms, then the mitral valve replacement is a class 1 indication. If they are not a good candidate for surgery, then PTMC is a R2B indication. If the patient is asymptomatic and have good morphology for mitral valve PTMC, then if the pulmonary artery pressure is greater than 50, it is a 2 indication for PTMC. And if the patient develops a new AFib with the morphology suitable for PTMC, it is a 2B indication. For patients who are having symptoms, but the mitral valve area is above 1.5, then we perform stress exercise. And if they develop the stress-induced pulmonary hypertension or symptoms, then we go for PTMC. So this is the survival benefit that we can attain from timely intervention on severe mitral stenosis patient. You can see that the patients who underwent timely surgeries, their life expectancy is near normal to the general population. So this is the comparison
Dr.
of
Shoaib, Dr. Shoaib, can you just hurry up because I think you are crossing the time.
Okay, sir. So this is the you can see that the cost of treatment is very high as compared to the cost of prevention, and we have to complete it. We can have LV dysfunction as well with mitral stenosis. The most common cause is the chronic inflammation, which causes endomyocardial fibrosis, or it can be caused with the tachycardia-induced cardiomyopathy. And then we briefly discuss the mitral stenosis in pregnancy. It is poorly tolerated, and the planimetry is the preferred tool for assessment of mitral stenosis in pregnancy. Then you can see the maternal risk. About 50% of the patient develop atrial fibrillation and thromboembolism, and 3%, less than 3% develop mortality during pregnancy. And prematurity rates, 20 to 30% patient having PTMC, they give birth to premature infants. And the IUGR rate is 5 to 12%. Stillbirth rate is 1 to 3%. So very high mortality in cases with the pregnancy. We have to either perform a PTMC before commencement of pregnancy, or if the patient develops pregnancy, then we have to perform the PTMC in the second trimester. So the modes of delivery, the preferred mode of delivery is vaginal if the patient is having moderate to severe mitral stenosis without pulmonary hypertension. If the patient is having pulmonary hypertension and NYHA 3-4 symptoms, then cesarean is the preferred mode. And the take-home message is rheumatic heart disease is a preventable disease, and it has a huge economic and emotional burden. Disease awareness and secondary prevention of ARF can effectively change the course of rheumatic heart disease. Timely intervention in severe mitral stenosis enables the patient to have a near normal lifespan. Thank you, sir.
Thank you very much, Dr. Shoaib, for an excellent presentation. You actually gave an overview of the pathophysiology and the sequelae of rheumatic fever, where you have rheumatic fever in young children, when we have that saying that the rheumatic fever is one which licks the joints and bites the heart. And then you talked about mitral stenosis and its management, and then mitral stenosis with pregnancy. I would request Professor Sohail to give his comments regards how can we prevent rheumatic heart disease in Pakistan, because in the West they have already been able to nearly completely eliminate it, but rheumatic fever is still rampant in our part of the world because of the poor socio-economic conditions that we have.
Thank you, Shabazz bhai, for asking these comments. Um, I'm hardly the right man to tell you how to prevent this disease. We do more PTMCs, 2, 3 a week, and even pregnant women. And so I would have, been more, um, uh, able to answer and shed light on those things. But um, I think I have a feeling that the incidence of rheumatic fever is reducing, or maybe we're not the right people to comment on it because they would tend to come in the pediatric uh, part of the hospital. Uh, Other thing is that there's been a rampant use of antibiotic by everybody in Pakistan. Maybe that has reduced. I'm not actually following this data very closely, but naturally we need to spend money on mother and child health. Rheumatic fever is just one part of the spectrum. In fact, you got to commemorate these and congratulate the public health people because uh, the country right now is doing a lot in terms of a vaccination of children, cards, and everything. And despite the fact that we are notorious for still harboring polio, but this government is making a lot of effort, and but we still seem to have an occasional case here and there. So I think they are people are there. We need to educate people, but then this thing is related to rheumatic fever is related to poor socioeconomic conditions which are prevalent in huge number of our countries, and because of the current economic situation, they're probably getting worse. Um, uh, so um, I wish somebody else would shed more light on this. Apart
So
from
it's
this,
basically, you see, basically, when you look at the world map, you will see that the incidence has reduced in Europe, it is reduced in North America, but in the sub-Saharan area, in South Asia, in these areas, it is still very rampant. And I went through some literature where in school children in Lahore also they found quite a high incidence of rheumatic fever. In fact, I remember in the 70s, we did a study in Islamabad where we looked at uh, the incidence of rheumatic fever in school-going children, and it was quite high at that time. It was reported in the Pakistan Heart Journal by Dr. Shaukat Malik and Dr. Shabazz and one more co-author. So the thing is that basically in the rural areas or in the other areas, the planning is such that you are not having the environment is not conducive to good health for children, especially in the low economic strata of the society. So probably what you need is, as you said, as you talked about it, that you need an awareness that this is there and this is what we need to do. And I think in those individuals or children who develop sore throat, you need to actually check, do a culture sensitivity on them. Unfortunately, with the indiscriminate use of antibiotics, there are problems and there has been a lot of resistance. And unfortunately, since penicillin, the long-acting penicillin, is out of market because it is a cheap drug and it's very useful. But I would like to have the comments of Dr. Akhtar regards what we talk about as primordial prevention, primary prevention, and secondary prevention. And for how long should we continue with the prophylactic antibiotic in these children who develop rheumatic heart disease, who have recurrent incidences? And I remember General Malik, Iftikhar Malik, who was a very famous pathologist from the armed forces, fantastic guy. And he actually, I remember he was presenting a study where he showed the Ashoff nodules still present in those individuals where these valves were taken out and prosthetic valves were put in. So the nodules are still there. And that is why I would like to have the comments of all the experts as to when they would stop using antibiotics in these children.
Thank you very
or
much,
in
sir.
these
Thank you very much.
individuals with rheumatic heart disease?
Thank you very much, sir. And it was very detailed discussion by Dr. Shoaib, actually. And as General Sohail has also mentioned, you very elaborately said that low socioeconomic status is the main cause of increased incidence, or the current evidence with 200 per 100,000 patients actually of rheumatic fever. It's quite a high number. And because we have a population with not only a low socioeconomic, because of that actually the lot of children, they are living together, and if one gets sore throat, all the family gets sore throat, and then one may be more vulnerable to develop a rheumatic fever than another person. So that is one story regarding the incidents. And how can we prevent the primary prevention? That is that we have to make these living standards better. Actually, at schools, they must be having a very good air conditioning and all those with which we can prevent recurrent infections, journal infections, and definitely the respiratory tract infection. A number of them is because of streptococcus, but otherwise viral infections and all those. So if we reduce those, primary prevention will be better. And we know that regarding this primary prevention by the penicillin in a high risk population, definitely that is an area which should be addressed in the population where there are pockets of this rheumatic fever. So that will be a good practice. Regarding secondary prophylaxis and how long it should continue, we know that it was initially 20 years, then 25 years, and then 35 years. And then they said that in certain patients where there is an ongoing insidious infection, you can continue even after 40s and all that. That is good, but we have seen recently, as Jan Sohail was saying, that we are not seeing much patients with acute rheumatic fever. Maybe they are being treated by the pediatricians or children hospitals, actually, where probably they are being taken care of. But I feel problem in a person who is 35 years or 40 years lady, and she comes with non-specific symptoms, and has some degree of mitral stenosis or like that. So should we start that secondary prophylaxis at that age or not? That is a problem which I'm facing. And most likely the clinicians like me as well, that uh, because if they are not taking up to the age of 35, what is the fun in giving medicine? Then we know that this rheumatic fever, the full-blown rheumatic heart disease occurs up to the age of 15, 20, 25 years. So if a person is having negligible kind of or minimal kind of involvement of the valve at the age of 40 or 45, I don't think there should be any logic to start a secondary prophylaxis or rheumatic fever at least. So this is my comment.
If you allow me a comment, Professor Akhtar and Shibasa, I don't know how many of you have taken your children and grandchildren to the pediatrician, and even we used to take our children to the pediatrician. They would be dead against giving antibiotics. I mean, the child has fever, he's got sore throat. They say, no, it's all viral. Just don't let
Yes.
you take antibiotics. And if you give it, they get upset, and so I'm not sure. And they are actually not talking about rheumatic fever a lot. They
Yes,
talk
I
about so many
agree,
other
sir.
things. Maybe we should have had a pediatrician sitting here amongst us talking about this. So I'm really at a loss. I think it's got to I mean, it's a huge country of 23, 24 crore. And I think it's those asymptomatic sort of infections which go unnoticed. Sydenham Korea has a very strong association with, valvular heart disease in rheumatic fever and the rash, and probably comes and goes. And we've got these very wonderful criterias which are very famous, especially for the exam. But, I mean, you hardly come across some so it's probably the poor socioeconomic condition, which I mean, Europe has certainly improved a lot in this, the pediatricians are doing a lot in terms of epidemiology, in the vaccinations and all. So we need to
I
really
agree with you, sir, because
this
there is some
also.
degree of disconnect because we are seeing a lot of patients of rheumatic heart disease, but we are
Yes.
not seeing rheumatic fever actually.
Yeah.
The reason
I
for
think
that, Professor, I think the reason for that is because they are being treated by the pediatricians. But Sohail, what I would also advocate, even though, the pediatricians must be treating them, but I think it is important that an awareness be created, because you see, if somebody has a viral infection, it is all right. But suppose it is missed and it was a group A streptococcal infection, and that was resulting in a rise in ASO titer and ultimately having its problems with its mortality and morbidity. So I think an awareness has to be created. The reason we were seeing more of them was because we were in a hospital where the pediatricians were in close contact with us.
So basically,
regards to secondary, in regards to secondary
Very much,
prevention,
can I
Dr. Akhtar, can I just,
can I-
Javed, I'm going to come to you. I'm going to come to you, Javed. Just let me make this comment. What Professor Akhtar talked about secondary prevention, I think it needs to be individualized, because those who have recurrent infections, they are the ones who would be needing prophylaxis for a long time. We have with us our past president of the Pakistan Cardiac Society, Javed Akbar Sial, a very dear friend, and I would request him to give his expert comments and the view which he has from the National Institute of Cardiology.
Thank you very much, sir. Indeed, great afternoon this Friday, and having an academic session and some sort of socialization as well. I really appreciate the organizer of this space, basically Tahir Shah, and our chapter coordinator from Islamabad, Akhtar Bandeshah, for holding such a nice meeting. Definitely, there are two issues. Number one, whether how can we prevent it? Number two, how can we treat it early? So prevention, it's straightforward that how West has taken care of this thing and they are free of rheumatic fever and rheumatic heart disease. Basically, this poor socioeconomic and poor hygienic conditions are responsible for this disease. And I slightly disagree with General Sohail Aziz Saab regarding its incidence has been decreased. It's not decreased. It's as what we are seeing, rheumatic heart disease, it's a very large number of cases, And last week in electrophysiological summit here in Karachi, one of our fellow from Aachen, he said that out of atrial fibrillation, he only see 5% rheumatic related atrial fibrillation and 95% non-rheumatic atrial fibrillation. So probably that's the way how Aachen people see the patient, because there is a certain class of patient whose socioeconomic status is quite higher. They go to these private hospitals. But if you're working in hospitals like we are working in NICVD, SICVD, where every patient has right to come, then you can see a lot of patients. And still their incidence is not decreased, but we hope that it should be decreasing. Regarding secondary prophylaxis, as Akhtar Ali Bandeshah said, and there are clear-cut guidelines for people like us are living in countries where this infection is endemic. Their guidelines say that you should continue the secondary prophylaxis with remnant rheumatic heart disease. Even people who has valve replacement, their prophylaxis should be lifelong. Thank you very much, sir.
So we have other colleagues with us, sir.
I think, Javed, you are right, because I think General Iftikhar,
Sir Qureshi, we have 5 minutes left, and there are a lot of people. There are a lot of
Okay,
other
all right.
papers actually.
Do you have, we have Abid now, and who else is present?
Dr.
Ahmed.
Hamid and Dr. Abid and yes,
Dr. Hamid sir from Registrar.
and from Sakhar as well, sir. Professor Sir from Sakhar.
I'll request Professor Hamid Iqbal to kindly make his comments regards it.
Sir, first of all, I'm thankful to all of you to provide me the opportunity to to be among the panelists. Sir, it has been rightly said by one of our professors that heart failure is not failure of the heart only. It is actually the failure of the healthcare delivery system. So early detection is important, and much has been talked about it. But one point I want to add is in the population like Pakistan, where rheumatic heart disease is prevalent, and we are living in a congested environment. So the patient who are having residual heart disease, valvular heart disease, should be prescribed secondary prophylaxis, that is benzodiazepine and penicillin, I think for lifelong till they are having the mitral valvular heart disease. Because I am seeing in my practice that these patients who are having residual heart disease, their disease is progressing day by day. So we need to give them prophylactic antibiotics lifelong, having the congested environment. The other important thing is preventing disabilities. Early detection of the mitral stenosis and early referral for the PTMC or valvular replacement is very much important, because in our practice we are seeing delayed referral for the intervention, and which is causing very much a lot of disabilities in the patient, sir. I mean, early referral for the PTMC or mitral valve replacement should be emphasized, because in our practice, being in the kind of tertiary care hospital, we see most of the patients who are a bit very late for the surgery.
Thank you so much, Hamid. You're absolutely right.
And I think there is one suggestion.
I remember a cardiologist to you with mitral and severe mitral, who comes to you with severe mitral stenosis, has atrial fibrillation and results in a stroke, is actually the failure of the medical system. Is Dr. Abdul Salam here also? If he's not present, then I would request Dr. Abid, who is the consultant cardiologist of the Capital Hospital and head of the Department of Cardiology, to kindly give his comments.
Thank you very much, sir, for arranging such a nice program. Actually, when a patient of rheumatic heart disease presents to a cardiologist, they are usually the adults patient. And most likely the process of the rheumatic heart disease has been started when they were kids. So it is very important, as said by other respected consultants, that the pediatrician's duty is very important in this regard. So the combined presentation or combined work by the pediatrician and cardiologist should be emphasized. And on the behalf of Pakistan Cardiac Society and on the behalf of today's discussion, I would like to suggest that Pakistan Cardiac Society should start some preventive program along with collaboration with pediatricians and cardiologists. Because the pediatricians, if they are trained enough, if they have good initial knowledge about to prevent the rheumatic fever, then in the coming years, the chances of the rheumatic heart disease will definitely be declined. So we should take on board the pediatricians regarding this aspect and to prevent the rheumatic heart disease in adult ages. Thank you, sir.
Rather, my suggestion is that as we are conducting programs for the prevention for the ischemic heart disease, if Cardiac Society may consider the suggestion that if we could make actually the groups which can go to the schools and make some kind of initial checkup of these kids, just a clinical one, so that if someone is having problems, so that should be early detected and prevented by giving the secondary prevention and all that. Professor Javed Syal may have a further comment on this.
that's we have preventive counsel, sir, as you know, and this is a great idea which you are speaking of, that prevention should be started from schools, and definitely we'll take this point in our upcoming council meeting, and we can start these kind of programs through our chapter coordinators, and probably you might be the pioneer of that program, and you start at Islamabad, then it will trickle down to other members.
Okay, thank you. Sir, question.
Actually, Javed, I mentioned earlier on that in the 1970s, we did a survey of the school children in Islamabad for rheumatic fever. We used to go to the schools. We actually examined about 15,000 schools in the different setups, in the good socioeconomic setup, in the poor socioeconomic setup, and all these places, and found out the incidence of congenital heart disease and rheumatic heart disease in these children, school-going children, and this is reported in the Pakistan Heart Journal. And I think we can continue to do that. It should be done. And above all, I think what you need is not only primary prevention and secondary prevention, you need primordial prevention, which means even before the incidence of sore throat, that you should be able to prevent it from occurring in very small children. That is how you will have an impact. Primordial prevention, primary prevention, and then secondary prevention. And I think it was an important seminar that we held today, where Dr. Shoaib actually covered the entire subject. He talked about rheumatic fever, rheumatic heart disease, mitral stenosis, because that is the most common occurrence of rheumatic heart disease. After that, you have aortic valve disease, and then you have tricuspid valve, or never pulmonary, but sometimes you can even get that. And then he talked about mitral stenosis in pregnancy. All these aspects are very extremely important, and he did an excellent job. The panelists also covered most of these subjects and gave their expert opinion, and I'm grateful to all of them. I think we have reached the top of the hour, and it is time now to close this webinar. Thank you, everyone.
Sir, you actually conducted it very well, and we are very thankful to the Pakistan Cardiac Society president, past president, and vice president. They made an excellent effort to make all these arrangements on this Zoom and rest of the logistics. And we are very grateful to our colleagues, General Sohail Aziz and rest of them. Professor from Sakhar, we could not get his comments, but I'm very thankful to all of you who have joined this activity from Islamabad. And Shoaib did an excellent job.
And he did an excellent job. But Abid, I just want to remind you that we have actually, the pediatric cardiologists are actually having programs for rheumatic fever and rheumatic heart disease. So we need to actually have a coordination with them. Before pediatric cardiologists, they were part of us at Pakistan Cardiac Society. Now they are a different organization, but they have very good programs also. Pakistan Cardiac Society can coordinate.
Yes, sir. Okay, sir. Thank you.
Thank you very much.
Right, Ji, everybody. Nice seeing everybody. Great session. Thank you. Allah Hafiz.
Thank you, sir.